Hello, everybody. We're going to record a session of This Week in Virology. So you might hear some of the same questions repeated, but it's okay because many other people are going to hear it.
You might get different answers.
Wow, that would be interesting if we got different answers, wouldn't it? All right. This Week in Virology, the podcast about viruses, the kind that make you sick. From ESCV 22, this is TWiV, This Week in Virology, a special episode recorded on September 7th, 2022. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. My guest today at this meeting is Professor of Clinical Neurology at the University of Edinburgh. Richard Knight, welcome to TWiV.
Thank you.
Do I get the pronunciation right?
Of?
Edinburgh.
Edinburgh, as far as I'm concerned. Yeah.
Well, thank you for joining me. We are at the last session of today's meeting, and standing between the audience and the reception is you and I. So we'll try not to go on forever. However, we are going to talk about variant CJD and BSE. But before we do that, we need a little background for our audience, which is not our audience today because they've already heard it. So let's start with the basics. What is a prion disease?
Well, a prion disease, as far as I'm concerned, is a disease in which there is a disease of the brain associated with the deposition of abnormally folded prion protein in the tissue.
Right. And we heard from Stan Prusiner that there can be different proteins involved, right?
Well, I think that's the difficulty. That's an expanded description of prion disease, because, of course, the neurodegenerative diseases like Parkinson's, Alzheimer's disease, and which people may be very much more familiar with than CJD, they also appear to have rather similar pathological underpinnings, and they're associated with the deposition of abnormally folded proteins in the brain, although different proteins. Whether you want to call them all prion diseases or not is something that causes disagreement in the prion world sometimes.
Okay.
And of course, it's at least confusing because the way that Stanley was using the term prion is perfectly reasonable. It's basically some kind of abnormal protein that's causing the disease. Mm-hmm. But the confusion arises because, of course, in prion disease like CJD, it's the prion protein that's affected. And so some people wish to reserve the term prion for those diseases in which the prion protein is affected.
So let's do that in our discussion. So the classic diseases like CJ, Creutzfeldt-Jakob, BSE in cattle.
Yeah, scrapie in sheep and goats, kuru, and chronic wasting disease.
In cervids, right?
Yeah.
And there are others as well in different mammals, right? Mink and...
Yeah, transmissible mink encephalopathy is another historical disease, yeah.
Okay.
And there's a newly recognized one in camels and dromedaries.
Really?
Yeah.
What is that one called?
Oh, it's called at the moment prion disease in camels and dromedaries. As far as
Okay. Doesn't have a nice name like CWD, right?
No.
Okay. That's a good one.
Well, not as far as I know.
I like that. Okay, so...
It could be called CAD disease, I suppose.
CAD, prions. Okay.
Camels and dromedaries.
Camels and dromedaries. All right, that's great. How do you acquire a prion? How would a human acquire a prion disease?
Right. Well, at the moment, there are 4 ways in which humans develop prion disease, effectively. The first of these is genetic. They have an abnormal gene that they've inherited from one of their parents, or else had a spontaneous mutation in the gene. And this produces an abnormal protein which is liable to misfold and causes disease. That's very clear. And 10 to 15% of human prion diseases are like that. The second main form is sporadic CJD, and sporadic CJD is called that because it occurs sporadically throughout the entire world. In every country where it's been looked at, in roughly the same kind of level, and occurs apparently spontaneously in middle-aged and elderly people. And at the moment, the current theory is it's simply a mistake, and that the abnormal proteins occur. We produce proteins, millions of them every second in our body, and mistakes are made. But there are quality control systems in the body which pick these up and deal with them. And as you get older, maybe your quality control systems fail, as I think Stanley mentioned earlier on. And to that level, it's a bit like some cancer theories, that we can produce abnormal cancer cells, but they get dealt with. But if our body's quality control system lets them free, then they start to develop disease. And then finally, there's a group of acquired diseases, and they can be really broadly speaking split into groups. The ones that concern us, there are two of them. One is variant CJD, which was acquired from infection from cattle in diet, and the other is what's called iatrogenic disease, and that's literally doctor-caused diseases where medical or surgical procedures have accidentally transmitted the disease from one person to another. There are other forms like Kuru, for example, but they are rather very specific, special forms.
Right. In all these cases you discussed, we're talking about the prion protein, either misfolding because of genetic.
All of these diseases they're quite different in the way that they are caught or obtained, as I've said. They are different in their pathology to some degree, and they're different in their clinical features to some degree, but they're all united by the fact that neurons in the brain, nerve cells, die, and this is associated with a conversion of a normal body protein that you and I are making at the moment, into an abnormal form.
So when we talk about diseases that are acquired, we often talk about incubation periods. So what would be the incubation period of these diseases?
Right, well, we can work out the incubation period for diseases where we know the point of cause. So for example, in Kuru, the cause was basically morning ritual cannibalism. Your relative died, and as a mark of respect, you incorporate them into your body by eating their material. And you can therefore go back to exposure at certain cannibal morning feasts, and work out the kind of incubation period. And secondly, the iatrogenic cases that occurred through dura mater used in surgery or human growth hormone, you can work out exposure times and when the person develops disease. And if you extrapolate this and say this is going to be true for maybe acquired prion diseases, the answer is it does appear to be measured in years, and very often around about sort of 8 or 10 years as a sort of averagey kind of figure, but there are reported cases of up to 40 years of incubation period.
Okay, and when you do develop these, what would make you go see a neurologist, say, and get diagnosed?
Well, it does depend on the disease because they are different, but essentially they are all brain diseases. So something goes wrong with your brain. And broadly speaking, they nearly always affect cognitive function like memory, thinking, behavior, things like that. But very often with associated other neurological features, typically things like imbalance in coordination, problems with walking, but also things like vision disturbances. So people would tend to visit a neurologist because they're becoming forgetful, they're unable to do things, they can't understand things, they get lost. But also maybe they become clumsy and are falling over and unsteady, and perhaps reporting impaired vision. But there could be a lot of different symptoms.
And how would you establish the diagnosis of a prion disease?
Well, for neurologists, that's of course a very difficult question in essence, because there are many diseases that cause people to do this, and many diseases that cause this are very common. So a young person presenting with unsteadiness in coordination and visual problems might have multiple sclerosis, or an older person might be developing vascular dementia or Alzheimer's disease. So there are many diseases which could cause this. And in general, a lot of diseases present in rather similar ways to begin with. So what a neurologist would do, is that they would look at the history and the clinical features, and they would then decide on what sort of investigations were going to be done. And because it's a brain disease, they would normally do a brain scan of some sort or other, and then they would be doing various blood tests, and then they might consider doing spinal fluid tests by doing a lumbar puncture, obtaining a spinal fluid. And one of the key features that would alert a neurologist to thinking about prion disease rather than some of these other things is because these initial investigations might be normal, which is not true for many neurological diseases, or they would show abnormalities which are very typical of another disease. So a middle-aged person presents with forgetfulness and unsteadiness. You do a scan and you find they've got a secondary lung tumour in their head. Well, then you've got the diagnosis. But the key feature of many of these diseases is that the initial investigations may be rather unremarkable, and they progress very rapidly. And so it's the progression of the disease over time and the exclusion of other illnesses that start to make you think about CJD. Because the first thing you've got to be careful of, and certainly for someone like me, who's seen a lot of CJD, but still does general clinical practice, is that these diseases, prion diseases, are very rare. So you don't want to think, oh, this could be CJD as your first choice. There could be other diseases which might be curable, or treatable at least. So it's an evolving process. And this is quite often difficult for the families because it may take time, and it may sometimes take a few weeks before you know where you are with the diagnosis. And because these diseases tend to progress very rapidly, the patient may have deteriorated quite a lot in that time. So it's very difficult for the families.
So it's basically, if you hear hoofbeats, think horses, not zebras.
Yeah.
That's the idea.
Yeah,
Now,
but once you've got to the stage of excluding common diseases and looking at the progression, you can then turn to certain specific tests. And that, for me, is the big difference. I mean, when I first started seeing people with CJD, there were no tests apart from an EEG, which was not very reliable. We didn't have brain scans in those days. Whereas now, there are a plethora of tests that you could perform, including tests on the spinal fluid and MRI brain scans, all of which may give you a big clue and allow you to diagnose people a bit earlier and a bit more accurately.
is one of these tests the protein-based amplification?
Yeah.
That's used in patients?
Yeah, effectively, the protein-based amplification tests are all about, you can detect abnormal prion protein. I mean, Stanley showed some Western blots and things like that. You can detect abnormal prion protein, but in many tissues outside the brain, in these diseases, it's at very low levels. Now, you could, of course, do a brain biopsy, but that's not often done in real life, as you might well imagine. Sometimes it's done. So if you feel there might be abnormal protein in other parts of the body, for example, like in blood or urine or something like that, then it's too low to detect by the methods that we have. But what you can do, clever people have actually hijacked the proliferation process that's part of the disease itself and used it in the laboratory to amplify the abnormal protein, if it's there, and to then get to a level where you can detect it. And there are two main varieties of tests that do this, and they've proved and are proving to be very useful.
But even if you can diagnose, there's nothing you can do to help the patients, right?
Well, there's nothing you can do to halt or reverse the disease process or to stop deterioration or death, but you can help people.
Yes.
You can support them, and also providing explanation to the relatives. And if you have a diagnosis, you can at least attempt to start to tell them what to expect and give a prognosis and so on. So I think that there are merits that do come of this. Although, to be fair, as a neurologist, the care of somebody with CJD is not that different in essence from the care of somebody with lots of progressive brain diseases. The principles are broadly the same. But at least people know that what the situation is, what the diagnosis is, and you're not spending a lot of time searching for something else.
So these diseases are 100% fatal.
Yes.
And what different kinds of human prion diseases? You mentioned Creutzfeldt-Jakob, Kuru. There's also Gerstmann-Strauss, I think, and some others. They're all clinically and neuropathologically different, is that right?
Well, the trouble is that diseases get named, and in the past they were named after the people who described them. I mean, Creutzfeldt-Jakob disease is a really interesting disease because Creutzfeldt never described the disease. And his name's attached by historical accident, but there we are. It would be reasonable to call it Jacob's disease, but it's called Creutzfeldt-Jakob disease. And Gerstmann, Streusler, and Schenker, people quite often miss off Schenker. It's always bad to be the third or fourth person in the list. It was a name given to a particular disease before anyone really knew what it was actually about. But I think we're probably moving away from that. And so what you can say is that human prion disease is sporadic, and we've called that sporadic CJD.
All right.
I mean, it just could be called sporadic human prion disease, in all honesty. The genetic diseases have been called different names at different times. So GSS, or Gerstmann-Streusler Schenker syndrome, is a genetic disease. It's one of the genetic diseases. There are other genetic diseases as well. And the acquired diseases have been called iatrogenic CJD. Yeah.
All right. That makes sense.
So Gerstmann-Streusler Schenker syndrome is one of the genetic diseases. It's become a problematic term because as we've uncovered the genetic causes and you find that different genes may be responsible, it starts to become a bit messy. It's not necessarily one homogeneous disease. And indeed, there are people who disagree about what the term GSS really means now in the modern world. And I think many people, and certainly I'd be one of them, would like to get rid of all this terminology and call it genetic prion disease, mutation E200K or something like that. But modern terms are never quite as nice, I mean, have you heard of Guillain-Barré syndrome?
Yes, I have.
Of course, there was a third person whose name I forget. It was his name Stoll or something. His always name is missed off.
That's
but I mean, nowadays it's called, acute inflammatory demyelinating polyneuropathy, which is fine, but it doesn't trip off the tongue.
I think Guillain-Barré is pretty good. I like that one. So what's the incidence roughly of CJD? So that would be the spontaneous, right?
Well, what I will rephrase the question and I will tell you the annual mortality rate.
Okay.
Right? So the number of people dying with the disease per year, right? It's roughly overall somewhere between 1 to 2.5 per million of the population per year in most countries.
So that's uniform, different countries of the world, pretty much.
Well, it's pretty uniform, yeah. They vary because, of course, there are certain countries who've perhaps got other things to worry about, who haven't done CJD surveillance, for which there are no figures available. And there are countries which have slightly higher rates than others, but that may reflect their health systems and surveillance systems. If you establish surveillance systems in most countries, they start to converge to around about 2 deaths per million per year.
So what is the surveillance system for a prion disease?
Well, that's a good question. I think the one lesson I've learned is that the surveillance system for any disease has to fit the circumstances of that country. So, if you compare what kind of surveillance system would you put in place in the USA with a much bigger population, a much more confederate state-based system, huge amounts of private, or at least what people call private healthcare, what they really mean is commercial healthcare, compared with the United Kingdom, which is rather more state-produced and more uniform. You need systems that are appropriate for that country. Certainly, when I started doing UK surveillance, there were more neurologists in the Bay of San Francisco than there were in the whole of the United Kingdom. So yeah, it's a very different kind of practice. But I think what you need to do is you need to get people to refer cases, clinicians, because they're the people who are seeing these cases, to some central unit. And that unit has to contain a neurologist. Because if you want to, say, do surveillance for HIV or something, you could do it through serology testing. There isn't anything like that for CJD, and you need somebody who's experienced in the diagnosis for CJD to review suspect cases. And the other thing about the surveillance system in the UK was we didn't have a notification criteria, because if you're looking to see if a disease is there and you don't fully know what it's like, or it could have atypical forms or be changing, if you just define what you want, you'll get those cases referred to you. And what you want is an iterative process where we say, send us everything. Well, not quite everything. We'll sort it out. Then we feed back to you and say, actually send us people like this and so on. So that's what we've done. But I think you have to have, it can't, at least in the UK, it can't be run easily by a public health system. It has to have clinicians involved.
It's like the early case definitions of AIDS in the US, at least, were Kaposi sarcoma, Candida.
Yeah.
Or PCP pneumonia, one of those two. Very simple and broad, right?
Yeah, exactly. Yeah.
And the same idea.
But I mean, if you said, for example, send us anybody of any age who's not quite right and falling about a bit.
Well, you get me thrown in there. All right, I got that. All right, so animals get prion diseases, as we've mentioned, and cows are among them. So let's start talking about bovine spongiform encephalopathy. So you talked earlier today about this outbreak in the UK. Previous to that, had we known of BSE in cows? We had not.
Novel disease.
It was brand new. And so how did people first pick it up? What were the signs?
Well, because obviously, first of all, I mean, I'm not a farmer, but my understanding is that cows do sometimes start to stagger around and die. They do this. But I think that it was the farm stock people who first kind of noticed that these cows were not behaving in a way that they really expected, and veterinary people saw them. And I believe, there were things like magnesium deficiency in cattle that can do weird things to them, but they obviously didn't respond to all these treatments. And then, of course, if they went to pathology, the pathology was very clearly different. And then it was the number of cases appearing once a few cases have been described.
And then after these the cows died, how long after they first had these symptoms typically? Or would they be culled?
Well, the difference between animals and humans is that if animals become ill, they are sometimes killed.
Right.
Or quite often killed. So, the other thing is some of these animals, I mean, it depends what animals you're talking about. Cows tend to be relatively monitored, but farmers do suddenly find that the cow has not been around for a bit and then found dead in a field. And of course, if a cow becomes ill, it's usually euthanized.
Mm-hmm. And so we assume the incubation period is long in a cow also, right?
Well, yeah, it is relatively long, but of course the difficulty is what's the exposure, and it was thought to be due to infection in feed. That was the result of the animal research. Yeah, it was thought to be due to feed. So
the cows are being fed animal protein.
Yeah, there were two things. One was that there was a tendency for animals that had died, ruminants, to be turned into food that was then given to other ruminants. And of course, cows, as far as I know, are herbivores naturally. So that was a slightly weird aspect of the farming food industry. But
they grow faster if you get the protein.
Exactly. It was, and the second thing was there was a change in the UK at that time in the way that material was prepared. And that change almost certainly was less good at inactivating infection. But as far as I know, it is still very uncertain what the origin of the disease was. And the origin that has been put around is, one, it was scrapie in sheep and cattle, the sheep that had entered in the food chain. That was a popular theory. My understanding is that that's not necessarily held anymore. And the second was that perhaps there's a sporadic form of BSE that occurs very rarely, like sporadic CJD.
In cows, right.
And that this was actually occurred and then was fed back through the BSE sort of food chain. But once it started, it was recycled and amplified.
Sure. Oh, so the cow dies,
it's
ground up and fed to other cows.
It was at the time.
All right. So what are the numbers of cows that eventually were diagnosed with BSE in the UK?
The total number I don't know. As I said, about somewhere between 450 to 500,000 cattle with BSE were thought to have entered the human food chain before regulations. There were, many, many thousands of cases each year in the peak of the epidemic.
And at what point did people begin to worry that this material had entered the human food chain?
Very early on.
Yeah.
I mean, people were worried about it after the first description in 1986, although at that stage the majority opinion was that it was probably not a risk, because it was thought probably to be scrapie or in cattle, and scrapie hadn't affected us. But that wasn't a uniform opinion. There were people who thought, well, even if it was scrapie, it's now been adapted to a new species. So very early on, the human food protection was put in place in 1989. And the first description, proper identification, description of this disease was 1986.
And when did we see evidence of a scrapie or a prion-like disease in humans in the UK?
Well, the first report was 96, and the first cases were in 94.
And you called this variant CJ because...
Well, it was called new variant CJD at the time for the very rather prosaic reason that it was a new variant of CJD. And then after a while, somebody said it's not new anymore, so the new was dropped off.
Okay, that makes sense.
But it has caused confusion because there are variants of sporadic CJD. Sporadic CJD is not a uniform disease. And then there was a vogue for calling it human BSE, but that somehow never really caught on.
I bet the press would like human mad cow disease, right?
Yeah, it's a very unhappy description. It's somehow stuck. People use the term still now. The families who are affected are deeply upset by the term. Many people in mental health were very upset by the idea of attaching mad as a descriptive term for this.
So you acquired it by eating beef, obviously, right? And it didn't matter how well it was cooked.
It depends what you mean by beef.
Okay.
I think what one can say is that it was acquired through BSE contamination of diet. If you mean by beef, bits of muscle cut out from dead cows, that may actually, for at least quite a wide variety of beef, may have been very safe. But other material from cattle may not have been. So, for example, because of the ways of preparation of cattle, including, bisecting the carcass and things like this, there was a big risk of contamination of material by the spinal cord or the brain. There were also, of course, the fact that the farming and food industries were driven by economic directives mostly. And so there was a vogue for having stripped all the meat off the carcass, then by things like high-pressure hoses or whatever, removing all sorts of gunky material from the carcass and forming it into a kind of pinkish stuff called mechanically recovered meat, which was then added to pre-prepared foodstuffs like sausages, pâtés, even perhaps baby foods, and wouldn't necessarily be labelled beef. The other thing, of course, is that brains were used. And I don't know if you've ever looked at foodstuffs, there's often a thing called emulsifying agent. In the past, not now, in the UK, one of the commonest emulsifying agents was brain. There wasn't really a lot of people wanting to eat brain as a whole in the UK, and that was used as an emulsifying agent. And I can't remember, but even I think in Germany, even in the year 2000, a survey was done of some sausages bought in Germany, and they contained animal brain material.
So it's not necessarily a hamburger, which is what I tell my students all the time.
We don't know, because we don't know. What we do know is that in a case control study, which is inevitably rather difficult to do and rather unreliable, the more often you eat meat products of certain sorts, particularly sausages, meat pies, burgers, and so on, it correlated with a higher risk of infection.
So even if you cooked, from what we know about the prion protein now, even if you cook the meat, it wouldn't inactivate infectivity.
Not necessarily, no.
Correct.
No.
You can't even autoclave the protein and inactivate.
Ordinary autoclaving doesn't necessarily inactivate it, no.
Right. So did the feed practice for cows change before the human outbreak?
Yes. Yeah.
And then the number of...
They changed in 1989, or thereabouts, I think, yeah. I can't remember exactly. Maybe even before that. No, it was before that, yeah.
Okay.
Yeah.
And then the number of cow cases declined within how many years? A year or two?
It declined from the peak pretty rapidly over a quick period of time,
And then
I can't remember the exact figures.
That's okay. And then as you showed, there was a delay between the peak of bovine cases and the onset of human, and then those cases declined as well.
Yeah.
Now, how many total cases were there in the UK of variant CJ?
Well, you've got to be careful because we classify the cases according to whether they're definite, that's proven by neuropathology.
Okay.
Probable, which means that on clinical and investigation grounds, that's almost certainly what they were, or possible, is you can only talk about cases that were definite and probable, and there were 178 in the UK so far.
And you also showed on a slide cases in other countries.
Yeah.
Are they mainly people who ate in the UK and then went elsewhere, you think?
Not necessarily, no. But they were people who probably, some of the figures, like the USA ones, almost certainly, yes, they were living in the UK at the time when they were likely to have been infected. But because we don't know for any individual person when it was they were infected or what it was that gave them an infection, we can't know.
And you mentioned today that anyone who lived in a certain period in the UK cannot give blood. Is that correct, because of this risk factor?
Well, initially, various restrictions were put in place on secondary transmission, and one of the things that some countries did, like the USA, Australia, Japan, was they decided that if people had lived in the UK or been in the UK for a certain period of time between 1980 and 1996, they would not be allowed to donate blood. It varied from country to country. Japan was the most extreme. It was 1 day. If you'd spent 1 day in the UK during that period, you're not allowed to donate blood. I don't know what's happened in Japan now, but Australia, Ireland, that's the Republic of Ireland, and the USA have relaxed their regulations on this. They've decided that the risk is not sufficiently large now.
So currently there are no known BSE cases in the UK?
I don't know if there are any BSE cases in the UK at this moment in time. There are occasional BSE cases still, and that's expected, a sort of a long tail off, although some of the cases are a bit difficult to explain.
But there could be sporadic.
Well, that's the other thing, that in the wake of all of this, oddly enough, no one spent a lot of time examining the brains of dead cows before. And in the wake of all of this, 2 new diseases were identified, one called BSEH and one called BSEL. And these do appear to be rather more widespread and occur in older cattle, and may well, I don't know, they may well be, as it were, versions of sporadic CJD in cows. But they've not been shown so far to be a problem for human health.
There's a lot of concern about this in the US and Canada, where sporadically they will find a cow with symptomatic, right? Because we don't scan all of our meat for, although I understand in Japan they do, right? They do scan for
Well, the USA did adopt a policy in relation to BSE, which was characterised by somebody, fairly or not, I can't say, of the form, if we don't look, we won't find. And if we don't find, we don't have it.
Yes, we just did the same with polio virus in sewage for the last 10 years.
And the USA is slightly different because the whole business of beef production and cattle ranching is a major industry with huge political influence.
So you're not worried that, the problem is that cows are typically slaughtered before they would show symptoms, given the long incubation period. So here in the UK, you don't check every cow for prion disease.
I honestly don't know what the present policy is, to be honest, because the other thing is that detailed surveillance of all cattle is horrendously expensive. I've no idea how many millions of euros the European Union spent on this.
Well, this is why this protein amplification assay is because they could just swab a cow and check.
I mean, there are various other things you can do, and one of the things that, in fact, has been proposed for humans as well is that if you stick something far enough up the nose, you will eventually get olfactory neurons, the neurons that detect smell, and these are, in fact, neurons. They're nerve cells. And people have used amplification methods on them to detect diseases. Right. So there have been all sorts of quick assay tests that have been proposed for both humans and animals,
So right now, there should not be any human developing variant CJ from this BSE outbreak. Is that right?
Well, I think it's always unwise to say that all regulations are always followed by everybody all the time.
Okay.
I think it's very, very unlikely, indeed, extremely unlikely, that new BSE infection would enter the human food chain in the United Kingdom. I think it's very unlikely indeed. But there will be people who, at least they're very likely to be people who have been infected with BSE in the past. I might be one of them, I don't know, who has got BSE infectivity potentially in their body, who are currently well, and who may or may not develop variant CJD in the future. I mean, one of the difficulties about incubation period that's long is supposing you are 50 and you are infected with an incubation period disease of 40 years. Well, maybe you're going to die of something else before you have a chance to develop that disease.
Do we ever see this in people who die of other causes if they happen to do a brain pathology?
Well, of course, it depends on where you are. And in the UK, it's not common. Autopsy rates have plummeted generally, and there's no kind of program for specifically for looking at normal brains. Interestingly, this was discussed a long time ago in the UK as to whether or not young people tend to go out drunk and drive cars and kill themselves, and then end up in coroner post-mortems. Mm-hmm. And there was a talk about whether we could try to sample material from young people who died accidentally or coroner's cases, but the coroner system was not keen to take part in that.
All
so
right,
it wasn't done.
I'm getting a sign that says, please finish. I will. I have three more questions,
okay.
And then I will finish. This artist license. So one of them has to do with CWD, chronic wasting disease, which is a big deal in North America. The rates seem to be increasing. It infects deer and other cervids, and there's people like to hunt deer in the U.S. and so forth. And so there's a worry that it could somehow enter the food chain, perhaps through pastures, cows getting. What are your thoughts? Have you thought at all about that?
Well, CWD is really interesting because the thing about prion disease is it is an infection, or can be an infection, but actually it's really quite hard to transmit it. You have to try really hard. Whereas chronic wasting disease is contagious, literally contagious for animals. So deers spread the infection from one animal to another by saliva and licking and things like this. So it's behaving in a very different way than many of the prion diseases we've come across before. And as you said, it spread very rapidly. I don't know, did you ever watch Bonanza?
Yes, I did.
Do you remember the map at the beginning?
I do.
And it starts on fire in the centre and burns. That's what chronic wasting disease maps look like.
Expanding,
They spread. Every year you look at them, they spread out. So there's no doubt about it that it really is a very worrying animal disease. The question as to whether it's transmissible to humans is quite difficult. All I can say is that the surveillance procedures in the USA, and CDC in the USA, are looking very carefully at this. And there has not been a notable increase in human CJD in the USA, and nor has there been a description of, hey, I've just found a slightly weird prion disease, that's different from all the others in the USA. So who knows?
You don't have it here in the UK. It hasn't been found.
It's not been found in the UK as far as I know. It has been found in other countries. Norway, for example.
Well, we can send you some deer if you'd like.
Well, interestingly, this is it leads you into all sorts of weird areas, because people said, well, how would the disease enter a country? And what I didn't know was, if you go onto the internet, I'm not suggesting you do this, and type in deer urine, you can get into a huge market of people selling deer urine. And I thought, why would anyone want to do this? And of course, it's wildlife photographers like to do it, because they lay it down and the deer come along.
They get
and stuff.
predators.
And hunters do it because then they attract the deer. And so it is entirely possible that deer urine has been imported into the UK. I don't know.
All right, and it's also possible that someone in the US is already incubating deer prions.
Possible.
They've eaten it.
Possible.
Because when they dress in the field, they're not
Possible.
always careful.
Yeah.
So we'll see.
Possible.
When that happens, then it will get you back, and you can.
I mean, I think there will be sorts of talk about how to encourage hunters to provide specimens and so on. But I think they tend to be a group of people with variable degrees of cooperation in this.
Well, you can find a website where they tell you how to dress out your deer in the field, but I think the hunters just probably do it the way they've always done it. So it's the kind of thing that's hard to control. All right, one more question. So we're supposed to conclude from this. What did we learn from the BSE variant CJD outbreak in the UK? What are a couple of things that you would say?
Well, I would say, one, this is a personal view. I'm not representing the institution. One is, I don't think it's a good idea to feed dead members of any species to their own species. I think it's a bad idea.
To their own species?
Yeah,
okay.
And probably. And secondly, I think that there have been huge pressures on farming, agriculture and the food industry to provide cheap food. And those pressures, I think, are concerning. And we don't need to eat, a hamburger every day or a steak for breakfast, really. And of course, interestingly, we're coming round to the point now where everyone's saying that for other reasons, it would be a very good idea to change our eating habits. And I would not be sorry to see if practice has changed and it resulted in certain items of food being more expensive and eaten less often. I think the other thing I've learned from it is that surveillance of disease in a country is actually quite a complicated matter. I mean, I probably knew this already. Simple questions you could ask, like how many people have Parkinson's disease, are surprisingly difficult to answer.
But really important, right? Like how many people have monkeypox virus infection, which we don't know. So let's go. I would argue that alternative meat products are becoming better and more popular, and we could replace all the beef, chicken, veal, whatever your favorite meat is, and reduce the risk of such diseases.
You can't, but of course there could be, who knows what will happen. I think there's risks in everything, aren't there? Okay. There's probably risks from eating certain kinds of plants.
There's a risk for recording TWiV because it's recorded in there forever and someone could use it against you. All right, on that lovely note, that is a special episode of TWiV at ESCV 22. We're going to do another one tomorrow at 12:30 in the room 11 upstairs there. That should be also quite interesting, so come see that. You can find the show notes at microbe.tv/TWiV. Questions or comments, TWiV at microbe.tv. We depend on your support to do this. We're a nonprofit corporation. You can go to microbe.tv/contribute to help us out. My guest today from the University of Edinburgh, Richard Knight, thank you so much. I appreciate the conversation.
Okay, thanks.
I want to thank the organizing committee of ESCV 22 for having TWiV here, and all of our supporters, and particularly Haley Hogvilla for suggesting this. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral. Thank you.